current status of surgery?
So, good afternoon. I think I'd like to thank the organizers for giving this talk. My talk should only focus on the pancreatic cancer because most of the data available is on the pancreatic cancer, not much data on periampullary cancer. So the concept of oligometastases was described by Hellman in 1995. Initially it was described for breast, and the concept is the patient with limited clinically detectable metastatic disease, and it is hypothesized that it might be a transitional state from the locally and few months to a disseminated virus spread disease. So local control of oligometastases in the early phase might be beneficial in long-term outcome. So they believe that the metastatic disease is limited burden with 1 to 5 minutes they categorize as oligometastasis. The problem is there is no consensus on definition, but broadly if you see the most of the places they have used the fewer less than 5 minutes localized to a single organ, not a poly-organ disease, and hypothesis remains that it is a phase of the cancer contained in one area and not cancer disseminated widely throughout the body. And it might be unable to curative or life-prolonging therapies such as local radiation or surgery in addition to systemic therapies. The problem remains whether these patients are true oligometastatic or it's a false oligometastatic disease, because patient might be having local metastatic disease which is not being picked up on your routine investigations. So whether it is true oligometastatic, that needs the confirmation by test of time, and that is why the role of chemotherapy comes first. The patient who after chemotherapy the disease remains stable, and these might be the true oligometastatic disease. So for these, one should give a basis for giving a neoadjuvant chemotherapy or a pre-operative chemotherapy in these patients. But always it is important is to consider the number of mets. If there is a number, bilobar liver mets more than 5, then it is a widely metastatic disease. Also take in account the history of natural history of disease, and that you can assess by after chemotherapy. And aim should always whether you want to cure the patient or avoid or delay the starting of systemic treatment. So these are the 3 cancers in which most of the time places the oligometastatic setting is well described, and it is a standard of care to offer these patients with treatment in oligometastatic setting, that is breast cancer, non-small cell lung cancer, and now for CS stomach and esophageal cancer, also there is a lot of data in which oligometastatic disease you can treat by local therapies. So coming to C-head pancreas, as you know, it is the 7th leading cause of death, and at the time of primary diagnosis, 50% of patients have a metastatic disease. And the most common site remains 90% in the liver, followed by lymph nodes and lungs, peritoneum, and nose. But with the better response to chemo like polyphenols, whether there is any role of local consolidatory treatment, and that is where the concept comes. So these are the few scenarios: the liver, peritoneal mets, lung mets, and the presence of interarteriocerebral lymph nodes. Lot of data is there for interarteriocerebral lymph node, whether one should proceed or not. But I will focusing mainly on the liver, peritoneal, and lung mets. So for oligometastasis C-head pancreas, the first definition was given by Demanskis, in which they have described that 4 or less than 4 liver or lung mets, and CA99 should be less than 1000. And there should be a response or stable disease after first line of chemotherapy. And Japanese almost similar, and they have used the peritoneal mets also for these patients, and their cutoff was CA99 less than 2000. The German cancer guidelines in 2000 described 3 or less than 3, synchronous metastasis, no metachronous, and but they are written as all these patients should be enrolled in a trial study. The present ESMO guidelines were they describe this for liver mets, it is less than 4, less than 3, it should be synchronous, and the disease interval should be less than 18 months, one should not consider metachronous disease. If the metachronous liver mets are less than 18 months, one should not consider. And there was no agreement on unilobar or bilobar, but it should be less than 3. For lung, there is a consensus that it should be 2 or less, and all patients, whether it's metachronous, should be taken. these are the various stages of pancreatic cancer, and based on which the ESMO consensus guidelines were given. So for surgical treatment, two minimal requisites should be there, that both the primary and metastatic tumors must be technically resectable and without need of any major liver resection. The patient must be good general ECOG status, and you expect that the median overall survival should be at least more than 11 months, which you can achieve by giving fulfilled. So one aim should be, it should be a survival, one should be able to use better than what fulfilled can achieve. So this is a Japanese series first reported in 21, and they showed that if the metastasis localized to single organ, limited volume disease, CA19 less than 2000, if you are able to resect, there is significantly better survival as compared to the non-oligometastatic disease. This is another study in which they have showed that if the CA99 normalizes and the liver disease is less than 2 cc volume, then these patients have almost similar prognosis as a non-metastatic disease. So concept is if the CA99 shows good response and limited liver disease, one can offer resection in these patients. So this is again definition published last year, but again you can see it is based on the number of, it should be localized limited disease. CA19 should be less than 1000, and these patients can be offered resection in these patients. What is the data for oligos liver metastasis in CA pancreas? All these patients can be offered conversion surgery, but there is no role of upfront surgery. If you think it is a resectable pancreas with resectable few nodules and you offer an upfront resection, then this is not, patients are going to fail. You start with the chemotherapy, if there is good response, you test the biology of the tumor and then do resection. Again, this is another from a Japanese center. They have also shown that the pre-operative chemotherapy is must. Never do upfront resection, even if it is a resectable upfront. So this is the largest series published from Buchler's group, and they have seen dissected around liver in around 85 patients, and they found that there is better survival and a superior survival as compared to palliative chemotherapy. Again, Japanese data, and they have also compared oligometastasis can be dissected with a longer OS survival as compared to polymetastatic or poly-organ involvement. This is the last meta-analysis published this year only, and this has shown that the oligometastatic disease or liver mets can have a valuable treatment outcome in a very selected group of patients. And these are the various studies they have included in the meta-analysis. These are other studies. All studies have shown that the limited liver mets can be offered a curative option in these patients. And these are the few trials, and I think MetaPrank is an American trial, and which is and German Holyprank. These should give a better results whether it can be offered as a standard of care or not. Till the time it is only offered at case basis or in trial settings. So what is the oligometastasis for lungs? So this Japanese study which shows that for mets, for lung mets, the median overall survival you can achieve up to 52 months. But the lung met should be only 2 or 3, and which should be resectable, and the primary also should be resectable. These are other studies which are also shown that lung mets can be resected if you have minimal 2 or 3 lesions. Coming to the oligomets in the presence of peritoneal disease, whether is there any role of HIPEC in these patients? So as you can see, the peritoneal disease upfront presenting in the CA pancreas around 10%, but most of the patients in metacognitive or progressive disease, it is second from the side of recurrence after the liver mets. But most of the HIPEC studies are used in the prophylactic or in adjuvant setting. Most of the studies are used gemcitabine and cisplatin combination, and most are in the adjuvant setting. If you find this is a locally advanced disease, you give HIPEC prophylactically to decrease the peritoneal recurrence. Only the Mayo Clinic have been using routinely for upfront peritoneal disease, and they have carried out a study in which they have shown the low volume peritoneal disease or only peritoneal cytology is positive, PCI less than 7, and there should be at least 6 months of systemic chemotherapy. In these patients, you can achieve a survival of around 31 months compared to systemic chemotherapy, which can give 19 months. but this is only for Mayo Clinic data. Most of the trials are for adjuvant setting. So these are the few Japanese studies. They have used selected group of patients with a limited peritoneal localized disease. You can have a better outcome by doing a CRS hyper in pancreatic cancer. This is the ongoing study. This is Mayo Clinic that is going as phase 2 trial, and this is the only using as a synchronous peritoneal medicine. So to conclude, the single organ limited tumor volume, whether it's a liver, lung, or limited peritoneal P1 or P2 disease, should get benefit from resection, but no upfront surgery. Always give chemotherapy at least for 6 months. Limited disease in liver for less than 4 beds. No extensive liver resection should be needed, and CA90 level below 1000 are the better candidate for resection. Lung has a good long-term survival if there is a limited 2 or 3 lesions. Peritoneal disease only a very few selected patients, not much data is available, and we need more prospective studies to draw a definite conclusion. Thank you.